Thank you guys very much. So thank you for the introduction. As Chris said, Angela and I are here as representatives from the Maryland Association of Behavioral Health Authorities to talk about the LBHA and CSA role in residential treatment center access. So the Maryland Association of Behavioral Health Authorities is a nonprofit, and Angela and I are currently the co-chairs of a subcommittee of that group. We call it the KAYA subcommittee, which is the representatives from our LBHAs, CSAs, and our local addiction authorities who work with children, adolescents, and young adults. And so we're just here to talk a little bit about our role in residential treatment center access. You'll notice we're specifically talking about LBHAs and CSAs, as this is a primary function of our role in those two agencies and not in local addictions authorities. We'll talk a little bit more with that as we go. So I'm going to pass this over to Angela Gray, who will take over the discussion.
Heather, can you hear me?
Yes.
Okay. Good afternoon, everyone. We just wanted to thank everyone for joining us today as we discuss residential treatment center access. If you have any questions during the presentation, if you could please put them in the chat box and we will address them at the end of the presentation. Our objectives for today are as following. I'm going to provide an overview of the local behavioral health authority, the core service agency, and local addictions authority and their roles in Maryland. Heather is going to describe the specific LBHA CSA role in relation to residential treatment center RTC access. And Heather is going to explain how to access local BHA CSA representatives. Next slide, please, Heather. We are going to start by laying the framework of understanding of the local behavioral health authority, core service agency, and local addictions authority. I'm going to outline their general roles and activities, and Heather is going to discuss their roles as they relate to residential treatment center access later in the presentation. Next slide, please, Heather. We wanted to explain the structure of the public behavioral health system and where the LBHA and CSA fit in. This is a tiered diagram outlining the structure. You see Maryland Department of Health is at the top, which used to be called the Department of Health and Mental Hygiene. The Maryland Department of Health is an agency of government in Maryland, which is responsible for public health issues at the state level. The Behavioral Health Administration, or BHA, is a division of Maryland Department of Health, which is responsible for oversight of the public behavioral health system in Maryland. The third tier on the diagram you see is the local behavioral health authority, the core service agency, and the local addictions authority. The role of these entities is to provide oversight of the public behavioral health system and implement state-level behavioral health work at the local level. The LBHA, CSAs, and LAAs receive funding from BHA, but we are independent entities. All of the jurisdictions in Maryland have an LBHA, CSA, or LAA. These should always be your first contact when seeking information regarding jurisdiction-specific behavioral health services. And the fourth tier of the diagram are the behavioral health providers, which provide services to individuals with Medicare, Medicaid, or uninsured or underinsured individuals, but not private insurance. They provide the direct service in the public behavioral health system. Next slide, please, Heather. All jurisdictions in Maryland are organized differently based on their level of system integration. An LBHA, which for some jurisdictions are in the local health department, they are a combination of the core service agency and the local addictions authority. Several jurisdictions have independent entities for CSAs and LAAs. The CSA is responsible for systems planning and management of the public behavioral health system, and the local addictions authority is typically responsible for substance use prevention and treatment services. There are subtle differences among jurisdictions, so we would encourage you to reach out to your local authority for specific questions. Next slide, please, Heather. We wanted to define the role of the LBHA, CSA, and LAA in broader terms and further explain planning, managing, and monitoring the public behavioral health system at a local level. The role of the LBHA, CSA, and LAA are to ensure individuals have access to a full range of quality behavioral health services across a lifespan. We advocate for policies to assist with prevention, early intervention, and treatment recovery services. We collaborate with system partners such as local government, local Department of Social Services, local care teams, or other stakeholders to improve access to care. And finally, we work to strengthen communities through outreach and education efforts to support behavioral health wellness. Next slide, please. We wanted to explain a little about the funding and the structure of services. There are two main structures of funding for fee-for-service and grant-funded. The large majority of services in the public behavioral health system are fee-for-service, which means the provider is billing Medicaid or Medicare. There are some specific but limited services available for those who are uninsured or underinsured. Fee-for-service funding is managed by the Administrative Services Organization, the ASO, which is Optum Maryland, effective January 2020. The role of the ASO is to act as the managed care organization, the MCO, for Medicaid. Programs who are fee-for-service are private, nonprofit businesses. Grant-funded services are typically used to bridge gaps in the public behavioral health system and the fee-for-service system. They are not reimbursable by insurance and may provide services to people who are underinsured or uninsured. Grant-funded programs might be pilot programs or specialty programs such as crisis services, mental health stabilization services, peer wellness and recovery centers, and adolescent clubhouses. Other grant funds can be used for eviction prevention, utility turnoff, or pharmacy assistance. Next slide, please. We wanted to explain eligibility criteria for the public behavioral health system. There are several eligibility components: financial, medical necessity criteria, the American Society of Addiction Medicine ASAM criteria, and the Administrative Service Organization ASO Optum Maryland criteria. For financial eligibility, as described in the previous slide, in regards to residential treatment centers, they would fall under the fee-for-service model, which would bill Medicaid. There are limited behavioral health benefits for individuals with Medicare and very specific programs for uninsured individuals, such as targeted case management for adults. Medical necessity criteria is related to mental health. For adults, medical necessity criteria is usually based on services for individuals with chronic mental illness, such as individuals with a diagnosis of schizophrenia or bipolar disorder. For youth, medical necessity criteria is less restrictive, typically based on a diagnosis, level of risk, and functioning. However, the primary diagnosis cannot be a developmental disability such as autism. ASAM criteria is used for substance use services and programs similarly to medical necessity criteria. The ASO is sort of the final step in determining eligibility for fee-for-service programs. They manage and authorize or provide approval for behavioral health care for individuals with Medicaid or those who are uninsured. And I'm now going to turn the presentation over to Heather Dewey.
Thank you, Angela. So we're going to dig into the meat of the role of the LBHA and CSA in specifically accessing RTC level of care. So just to kind of set the stage for residential treatment centers, this is the only type of out-of-home residential program that the LBHAs and CSAs can access for youth. There are some kind of criteria around that for when we would be called what's the lead agency. So for instance, the LBHA or CSA cannot be a lead agency for a youth if they are already in the care and custody of the Department of Social Services or Department of Juvenile Services. Those agencies in those cases would be considered the lead. However, we can be the lead agency for youth who are 13.2 years of age or below at the time of when they are trying to gain admission into an RTC, as long as there is no need for DJS or DSS involvement. So for instance, in that case, it's primarily youth who are looking for an RTC level of care at St. Vincent's Villa. The reason that we are able to be the lead in that case specifically is because youth who attend St. Vincent's Villa Residential Treatment Center for treatment attend school in the community. They do not require a private separate day school individual education plan or IEP. For other youth, we may be the lead if they are ages 13 to 17 when they have a non-public IEP and medical assistance. So for these cases, we're generally the lead if they have medical assistance and if they have a level 5 non-public IEP, with the exception being youth who are trying to access treatment at St. Vincent's Villa, again, because they access the general public school system without an IEP in place. The reason for that is RTC is funded by two pots of money. The first is the residential component, which is covered by medical assistance. And the second generally is an educational component, which is funded by the level 5 non-public IEP. So our ability as the LBHA or CSA to be a lead is really based on what we can access for funding for those youth. When we are the lead for a youth who is obtaining RTC level of care, we really serve two functions. And this is really important because it looks a little different than when Department of Social Services or Department of Juvenile Services may be the lead. We fulfill an administrative role, which means we review all the RTC applications, even those coming through DSS and DJS, to determine if medical necessity criteria or MNC is met. Angela talked about that a moment ago. So we're looking at all the youth who are wishing to bill medical assistance for an RTC admission to make sure that they are eligible for that level of care based on the Medicaid guidelines. The second role that we would play as a lead agency is really a technical assistance role to the treatment team. So this looks a little different from Department of Social Services or Department of Juvenile Services, who often will be involved and have care or custody of a youth that they are working with. Our role as the LBJ or CSA does not have us gain care, custody, or guardianship for a youth or family. So we are providing that technical assistance for the treatment team and sharing our expertise and knowledge. We're providing consultation and helping those folks navigate the local systems of support. So for instance, if there's an outpatient mental health provider and they are looking to access RTC level of care for a youth, they would create the documents or the certificate of need that is required for that. And we, as an LBHA, may direct them, here's the list of providers that you can send that to, all of the RTCs in state and out of state. We would provide them instruction, we would provide them assistance, but that treatment team would really be leading the application process. Whereas a youth who may be involved with Department of Social Services or Department of Juvenile Services, that agency themselves would be leading that referral process. Again, custody and guardianship is maintained at all times by the legal guardian when the LBHA and CSA is a lead. So that may be a birth parent, an adoptive parent, somebody with court-ordered guardianship, but we do not obtain that custody and guardianship. So a lot of our role is really based on some of that limitation for what we are able to do. We can provide assistance for families and treatment teams, sometimes without ever talking to a caregiver. So one of the kind of things with that is, again, with DSS or DJS, that lead worker may be directly doing those referrals. But in our case, we may be providing TA to the clinician or the psychiatrist who's already directly working with the family and would be providing that referral process. So there are times we may be helping to access RTC level of care without directly working with that caregiver or youth. It is important to note that some LBHAs and CSAs look a little different. And I think sometimes this is where some confusion gets in, is there's a lot of local nuance. For instance, some LBHAs or CSAs obtain additional grant funding where they can provide more assistance than just the technical assistance. They're able to provide supplemental supports above and beyond that TA, and that may include things like helping with the referrals directly, attending multiple treatment teams. But again, those jurisdictions have obtained extra funding to do that above and beyond service. So it's really important to make sure that we all understand what the baseline, what the general expectation is, and connect with your jurisdiction specifically, your local LBHA or CSA representative, to see how your jurisdiction actually facilitates this treatment access. It's also important to remember that LBHAs or CSAs must be notified by the local Department of Social Services if a voluntary placement agreement is discontinued. So sometimes, if a youth is coming in and let's say they have medical assistance, but they do not have a level 5 non-public private separate day individual education plan, that family would be connected to the local Department of Social Services to potentially access residential treatment center care through a voluntary placement agreement. After that youth is admitted into the RTC, there are times when they will then become eligible for a level 5 non-public IEP. At that point, a VPA could be closed, which would transition the lead from the local Department of Social Services to the LBHA or CSA. But that needs to be a process where your LBHA or CSA is notified that that happens. We always recommend, so if you guys hear these are coming up, that the Department of Social Services really discuss with the family prior to closing the VPA what that transition looks like. Because again, having the LBHA or CSA as the lead looks different, it functions differently than having the Department of Social Services as the lead. And we want to make sure the families are coming in with expectations that are clear, and so they're feeling supported and they understand how those differences look. We want to talk about the potential impact on services. So for instance, we as the LBHAs and CSAs cannot access a level of care like a therapeutic group home. And we also want to make sure we're just discussing how things look different, the shift from case management to technical assistance. So our goal in this is really to make sure youth and family feel supported when that transition happens while maintaining continuity of a lead role. And then as we talked about, every jurisdiction is a little different, and we want you guys to have knowledge of how to connect locally with your jurisdiction. So hopefully everybody has somebody from their LBHA or CSA attending their local care teams. I know I've had the pleasure of participating in the Baltimore City team with Renette prior to coming into my new role, and now I'm with Baltimore County with Mary Leslie, which has been wonderful. I know Angela participates with her Harford County team, and each jurisdiction is supposed to have a representative from these organizations on the local care team. There is a directory, we call it the CAIA directory. Again, it's the Child, Adolescent, and Young Adult Representatives from the Maryland Association of Behavioral Health Authorities that we maintain regularly. And every time we update that directory, we send it to Chris. You may even received it from some of us directly in your LCT meetings who have shared that out as well. That is the best place to go to look at your specific jurisdiction and find out who your contacts are. We update that regularly, and you should have received a copy of that before this meeting. And our biggest takeaway, again, because there's lots of nuance, is talk to your local jurisdiction. If you have a case and you're not sure who should be the lead, what does the lead look like? What can the LBHA or CSA do or not do? Call your person, look at that directory and reach out. We're happy to talk through that nuance of how each jurisdiction may work and let you know what we can do in our jurisdiction. We definitely want to be here to help and make sure everything is smooth sailing and there are no barriers to accessing treatment that a youth and family may need. So we're going to go to questions in the chat as well, and I think open it up. But just in case, you guys should have a copy of this presentation. I know Caroline Jones is with us from the Behavioral Health Administration. So you want to give a shout out to her and her team who helped us put together this presentation. Make sure what we are sharing is consistent across the state. So you guys should have this as your baseline across all jurisdictions. And of course, this is mine, Angela Gray's contact information. We have the current co-chairs for the MABA-CAIA subcommittee, and we are also happy to answer any individual questions. But again, we always recommend that you go to your local representative first. And just as a little kind of to see what that directory looked like in case you have not seen it, this is what our MABA-CAIA directory looks like. So you can see each jurisdiction will list the specific child, adolescent, and young adult representatives. So for instance, I'm in Baltimore County. So you can see my supervisor, Ari, my colleague, Tiffany, myself, And then our local addictions authorities partners, Amy and Pam, are also on here with our emails and how to contact us by phone and fax. So there are representatives from every jurisdiction, and this is who hopefully is engaging in your LCT, but also who you could contact if you aren't able to connect with that person. I'm going to stop sharing my screen and open it up for questions. And we know you guys got some. We are asking, I should say, and I apologize for not saying this earlier, we are asking, since we are recording, I think, that we not do any protected health information or youth or family specific questions while we are recording, just to protect privacy of folks. So if you have kind of a system question, maybe just think about, would someone know who that youth is? Can you make it general? And if it is youth specific, contact your local person, or you can reach out to Angela and I after this meeting. So just want to throw that caveat out there for folks.
Yes, thank you, Heather. Go ahead, Mary Leslie.
Nice presentation. Thank you, ladies. I just wanted to, I know the answer, but I think that maybe some others don't, that do you handle out-of-state placements?
So that is a great question. And what I will say is we technically can, but there have not been an out-of-state placement with an LBHA or CSA as a lead in several years. Now, that being said, Mary Leslie knows I'm working on some, because that's my luck, that happened to have just happened in Baltimore County. So if it does come up, our recommendation would be to talk to your local representative. The biggest reason there's some nuance around that is our level of monitoring looks different than Department of Social Services or Department of Juvenile Services. So for instance, in Baltimore County, I am one of a team of 3. If we have an out-of-state placement, we are technically not funded to travel to that placement to see that youth in face-to-face, as some other departments may be. And so depending on the needs of that youth and family, it may or may not be appropriate for them to have that level of monitoring. They may need more. So we would say to definitely talk to your local contact to see what that looks like. The list of eligible residential treatment centers that all accept medical assistance was shared by Chris prior to this meeting, and it does note both in-state and out-of-state RTCs that accept medical assistance. Again, another nuance is they may accept medical assistance, but may not be funded by MSTE, which can create some things too. So always locally bring that up with your local person. It's new for a lot of us because, again, it does not happen often. And so it's certainly a journey. I know I've been lucky with Mary Leslie that she joins me in that journey, and we work on that as a team through our local care team. And I hope that you guys can navigate that as well. And shout out as well to our BHA representatives who are helping us navigate those out of states as they come up. So it is possible. It is super infrequent, and contact your local people to really coordinate that specifically. Angela, did you have any different perspective on that, or Caroline?
No, yeah, I would just add it's very infrequent because, to be honest with you, our ability to monitor an out-of-state program is non-existent. So we definitely don't, we really don't encourage taking the lead unless we really have that ability to partner with one of our sister agencies in assisting us with monitoring a youth in one of those Medicaid approved programs. So that's why we have to make sure that we have education or juvenile services. We kind of want to make sure that they are aware of a youth if we need to be involved with the youth going out of state.
Yes, there's a lot of nuance to an out of state, and ultimately the goal is we want to make sure that this youth and family are protected while they're out of state. And sometimes there's certain levels of monitoring that need to be in place to ensure that.
Heather, this is Arian. And I know in the rare situation that I had encountered it in the past with Anne Arundel County, we actually encountered that the person was not eligible to have their Maryland state medical assistance transferred to that state. So then there's also that institutional medical assistance that comes into play, even after you've done all this hard work and found that the child was not suitable or didn't meet the criteria for all of our in-state facilities. And then you start looking out of state, and then you have that happen.
Yes, thank you for pointing that out. We we wish we had all the answers, but the struggle is real sometimes with residential care. And in some ways it's good because we want kids to stay home. Like we want kids to be, and families to be as close as possible and as connected as possible. But when there is a need, we also don't want to have any barriers to that. So it can be a challenge. My understanding is the current list that we have that was shared with folks does list the Maryland Medicaid approved RTCs presently, but as you noted, sometimes there could be changes. You know, something could have happened and an RTC withdrawals, or maybe a suspension has been put on there. That's why there's always important nuance and navigating that individually. And I'm hoping, you know, that partnership you had in Anne Arundel County, they're a jurisdiction that has supplemental funding, so they're able to do a little more than technical assistance. It's really important with navigating those things. Great question,
Hi.
Mary.
Hi, I'm Mary from St. Mary's County, and the autism issue that was brought in it's become a huge problem in my county. We just are having incredible difficulties trying to place kids who are on the spectrum, usually very, very low on the spectrum, who we just can't find anybody who's willing to take them. What are your suggestions? How does our team navigate this issue?
So Angela or Caroline, feel free to jump in, but I think making sure that you have a really clear diagnostic evaluation with a recommendation is important. We do have youth who are co-occurring, but there are mental health needs. And so depending on those evaluations, what are the presenting behaviors, what is the type of treatment, can definitely impact a program's willingness to accept based on if they perceive they can provide that support. So we always say if they haven't had a neuropsychological evaluation, that can be really helpful. A functional behavior assessment, or an FBA, could be really helpful. Also making sure those families have been connected and determined if they're eligible for DDA services, which could perhaps be helpful prior to a residential admission, could also be beneficial. DDA, and I don't know if they're only, I think Janet's here, they've been amazing to partner with. I know we have had them helping with us with serving youth, and you know, once a youth is 18, potentially accessing different levels of care. They did a great presentation for our team, all of our locals, last month, so even we could better understand that. Also, doing those referrals and having accurate assessments and making sure those are going out to the RTCs is really important. And I think just in general as well, what we would say is the local care team can be helpful because at least you're bringing that DDA, LBHA, all those folks together to see, like, we've reviewed the assessments. Are these good assessments for an RTC, or are they going to read full developmental disability? You know, how do we work that out?
Right. Often though, I'm hearing that IQ has a big is a big factor in placing these kids, and boy howdy, you know, what do you do with that? And especially with DDA, we feel stuck between a rock and a hard place. And for children with and often teenagers with severe behavioral issues.
I don't know, Caroline, and I'm putting you on the spot, so feel free to say, Heather, you talk about it. The Behavioral Health Administration has noted that there's kind of some of these challenging groups with accessing RTCs, and they did recently release what's called an REOI, a request for expression of interest, specifically working with residential providers to try to create some programming with additional funding that may make some of those providers more amenable to accepting those youth, because they'll feel like they can support whatever additional services are needed, whether that's staffing or physical plan. So that's something that's underway. Caroline, I don't know, is there an update or any information if you'd like to share about that?
Actually, I don't have a whole lot of information. I know that they've had a forum, and to be very honest with you, I haven't been totally involved in it because I've been doing some other assignments, but I can say that what the youth that they're really looking at working with right now and giving the priority to are those youth that are stuck in the hospital. So yeah, I'm not quite sure how many beds are going to be funded or where, or if there was really interest from community. So I'm not quite sure.
So Heather, this is Janet. I can give you a little bit of an update. Tennille and I have been involved in that process. The request for expression of interest went out. There were 3 or 4 providers that responded. And because most of those providers were focused on only one specific group of youth, we did hold a meeting on Monday to try to bring more providers interest in. Not sure if it convinced them or if it didn't, but we will be continuing to work on that. I think that initially they're looking at about 25 youth in the first year, but maybe only 18 beds because it's supposed to be short term. And it will hopefully be, at least the purpose was to kind of hit on a lot of the really high risk kids that are in the hospitals and stuck with a variety of issues, not just DD or behavioral health, but with a whole variety of issues. And some of those kids that you guys are getting pressured at the LCTs to place. So an actual grant application will be going out, I think, in early May to providers to try to bring them into this process. And probably the best place to get any information is on the behavioral health website. Right now, I think the REOI is on there, and as other stuff. I think there's a recorded presentation.
And it is a great recording. Thank you for reminding me of that, Janet. I listened to that recording just to learn more about what is this? What are they thinking? Who is this intended for? And it really was great. And I will say they gave a shout out to LCTs as being really key in coordinating around some of these youth. I think it was, I messaged Mary, I think it was around like 5 or 8 minutes in or something like that. You guys get a shout out. So thank you for sharing that update, Janet.
Okay, well, yeah, I'll have to look that up. REOI. Okay, and you know,
this is Tammy. I can share that with you as well.
Thank you. Oh, thank you, Tammy. She's my Southern Maryland girlfriend. Yay! Thank you. That's enough for me.
All right. So going back in queue here, we have a question from Jenny in my office about a state directory or a local directories of behavioral health providers. Jessica Sexar replies that LBHAs and CSAs are required to maintain directories of service providers and that each jurisdiction handles that a little bit differently. Anything else general to add to that?
Yeah, go ahead, Angela. I'd say yes, contacting your local person is great. I know in Baltimore County, we maintain lists of our outpatient providers, our substance use providers, our PRPs, and those are readily available at any time and updated regularly. Behavioral Health Administration also works with 211 broadly, which could be a support, but we always recommend contacting your local person. They probably will have the most up-to-date information as to which providers are available and how to best connect with them.
All right, and then from there, we have a question from Jan Willis.
Hi, I just was very interested in, I think you called it the supplemental funding to the CSA or the LBHA, and how to find out. I can certainly reach out to Audra at our CSA, but whether they receive that funding and how they could receive that funding. We've recently had a case that's arisen that's a little more tricky, and I wasn't aware that there was supplemental funding potentially out there. Anyway, how do we know?
So I will say it's the money that is received by every LBHA, CSA, and LAA is different and specific to that jurisdiction's needs. So for instance, when I was in the city, we had a certain pot of money that was available for what we called flex funding. We also have that available now that I am in the county, but for different things and in a different amount. So that was based on jurisdiction-specific need. The needs of the city youth and families look different than what were determined to be the needs of the county youth and families. So connecting locally with your person is really important. We actually just went through our annual plan process, and some of us are still in our reviews to see what that funding looks like. And if any of your jurisdictions publish, they should be publishing, Tammy, correct me if I'm wrong, I believe annual plans are public and can be shared. They are lengthy, so prepare for a read. I don't think I've seen one smaller than 100 pages. But if you want the details of what is being used with that funding, that is a great place to get the broad, every detail information. But connecting with your local person is probably the quickest way to see what's available and do a case specific. So for instance, when we have this come up, Mary may say, you know, what do you have? And we have an overview. We have our Flex Fund application. I can send those things specific to that family. Rather than reading our 100+ page document. But if you wanted to dig into what is available broadly, that's a great place to look, and your local representative should be able to share your most recent version of the annual plan. They're in that planning review process right now, so some of them are waiting for finalization for the most recent plans.
Great, thank
So
you.
this is Arian again, and isn't that also the difference in that also is that some of them are county government, some of them are state government, and very few are still nonprofit. And a nonprofit, for instance, they are able to write for specific grants and apply for programming things that the local county and the state are not.
Yeah, I think it depends. Sometimes things can be easier. So for instance, Angela can speak. She's with more of an independent agency, whereas I'm in a health department. Her budget approval process looks very different than my budget approval process. You know, we may have a board of estimates or things we have to go through. Angela does not. So sometimes there's different flexibility, different ways things happen. And so the maps to get to money can look a little different jurisdiction to jurisdiction. So just like with you guys, you know, some of you may be in health departments, some of you may be in different kind of ways, but it can look a little different jurisdiction to jurisdiction with how that funding is accessed and how it's implemented.
I think that was the beauty of the program you mentioned that we used to have called Flex Funds, that flexibility.
Yeah, I mean, we're lucky. Part of being like the county health department is some of our flex funding, additional money can come from the county. Whereas when I was with an independent agency before, we didn't have that kind of option. So there's pros and cons, lots of different ways. We're all making it work and we're all in this together. And wants to start singing some High School Musical, figuring it out. It can be a challenge.
All right, thank you. So moving to Laura from Charles, who asks, any tips for when a youth is deemed in clinical need of RTC, however, youth are denied placement by RTC because their behaviors are too risky, but certainly also too risky to stay home? Her understanding is that within the RTC's, it is within the RTC's right to say no, but then where else can they go, not only for their needs, but also to keep their family members safe?
Yeah, that's a challenge. We're in the boat with you guys on that too. As Angela mentioned, residential treatment centers, like our public behavioral health providers, are generally private nonprofit agencies. Now we do have RICA Baltimore and JLG RICA, which are state residential treatment centers, but the majority of them are private nonprofit. So independent businesses. I think the good thing about working, and again, it depends on who's your lead. So if DSS is your lead, there could be a different dynamic than with DJS or with your LBHA or CSS's lead. Get with your lead. Generally, most lead agencies have really good relationships with our residential treatment centers. I know Angela and I have been on the phone with our admissions coordinators. Sometimes this is where having a really accurate referral packet or certificate of need is important. Because if there's a lot of broad things in there and it's noted as historical, but doesn't say it's been 10 years since it happened and nobody's worried about it, they may just say, oh, this kid has a history of fire setting. This kid has a history of sexualized behaviors. Yes, they do, but maybe that hasn't been demonstrated. Maybe these things are resolved and their current needs look different. So working together to have that those packets be accurate. Use your lead to liaison with your admissions coordinators can be helpful. And we always try to see if we can do an interview. Like, would an agency be willing to do an interview? Because maybe that would give a different impression than just reading the packet. But I know having those packets up to date and including letters that may provide clarification is important. But it is a challenging, nuanced process. And so I wish I had a good answer for you, but agencies do have the right to decline. And in those cases, getting together for an LCT to say what's available in the community, what can we try to do to stabilize, or if they're in a hospital, what can we do? How can we make sure we're noting progress as soon as it happens and updating that RTC referral to see how we can navigate can be really helpful. I know there's also cases when we're lead where we'll connect with the Behavioral Health Administration. So often we'll talk with Caroline Jones, how can we help navigate? So there is no really great one quick, this makes it easier. I'd say connect with your lead to be able to connect with your RTCs and talk about the nuances of that case and making sure that you're noting strengths. It's always a thing too. I think we do, our assessments focus a lot on the problems, but include your strengths in there too. Do you have an involved family? Do you have someone who's willing to help? Does this kid respond to certain things the RTC would offer? Those can all make them look like treatment would maybe be a potential option for them at this agency versus perhaps something they wouldn't benefit from the RTC's opinion. Angela, do you have any other ideas or tips or tricks?
I just wanted to, add to that and reinforce what Heather said about connecting with your lead agency. And like Heather says, the LBHA CSAs have really good working relationships with the admissions coordinators at residential treatment centers. So, maybe having a conversation, what would the residential treatment center need to feel confident and comfortable in treating this youth? What might that look like? And sort of how do we problem solve around that? Maybe they would be willing to accept this youth with this condition or that condition. And so how can we sort of make that happen, and having those conversations about, clinical appropriateness and who could support helping them feel confident in being able to treat this youth.
Thank you.
All right, thank you, everyone. We'll go to Deirdre asks, are there any facilities in state that as of now work with youth that have Prader-Willis syndrome?
No, I've seen that. And Angela, you're muted, but I see you shaking your head too. There are none that I am aware of in state specific to Prader-Willi syndrome. And so I know that's something I've seen worked out at different jurisdictions in different ways, either through MSC funding or through DDA or VPA with accessing those. It's generally not a behavioral health diagnosis that we often encounter. And so that specialization across the country, there's actually really limited RTCs or residential programs that note specialization in that treatment. So I am not aware of any in-state presently that specialize in that diagnosis.
I'm Mary.
Thank you.
Hi, I'm Mary Flood from St. Mary's. We were able to place a child out of state in Massachusetts. He's doing quite well. He's been there almost 2 years now and is making great progress. So if you want to, Deidre, call me. I want to see pictures of your grandbaby anyway. So get in touch and I'll let you know where this child is and what this facility is like, okay?
Okay, thanks, Mary.
All right, and then while anyone else is adding their questions to the chat or putting up a hand, Heather has shared in the chat links to the REOI and also a webinar for SAME. So I'll be sure to include those links in the minutes. Tammy, is that a fresh hand that's raised? Might not be fresh. That's it for the, oh, there's Deirdre. Go ahead, Deirdre. I'm sorry, either Tammy or Deirdre.
My hand wasn't supposed to be raised.
My hand wasn't raised.
We'll blame Google today. All right, any other chat questions coming in or Any other questions live?
Well, we really appreciate you guys making time for us. Again, we know it can be a challenge. I think all of us really want youth and families to stay together, but also get the services they need and not experience barriers. So please connect with your local people. If there are specific questions that come up that you think are system-wide or statewide, please feel free to pass them to Chris and we can connect back and certainly bring any of those to the group. I can say Angela and I have been regularly meeting with Chris and some of our other partners from GOC, PYVS to make sure we're linking between our LBHA, CSA, and LAA reps and you guys. So what you hear, we hear. What we hear, you hear. So hopefully that consistency of communication and coordination can really help us all with partnering. And we appreciate your patience as we try to figure all of this out even a year into COVID. It feels like it's changing every day depending on what's happening. So thank you so much for having us.